right, welcome to the Explainer. So on your medical exams, you are going to get hit with questions designed to trip you up, right? They're testing if you can spot that one tricky diagnosis hiding in plain sight. Today, we are tackling a classic one, tuberculous meningitis, or TBM. Let's break down exactly what you need to know to absolutely nail this topic.
So what are we talking about here? Well, the answer is tuberculous meningitis. This isn't an infection that screams for attention like your usual bacterial meningitis. Nope. This one smolders. It's sneaky, it's incredibly dangerous, and you can bet it's a classic diagnostic challenge that you will be tested on.
Okay, first things first. How does a patient with TBM actually show up? I want you to forget the sudden, high fever, can't move your neck storm of typical pyogenic meningitis. TBM is completely different. Think of it more like a slow burn.
The initial symptoms are so frustratingly vague, and that's a huge clue for your exams. A really great way to remember these is the mnemonic feverish. That's F for a low-grade fever, E for exhaustion, V for a vague headache, E for emesis or vomiting, R for reduced appetite, I for irritability, S for night sweats, and H for, well, more headache. It's this sneaky 1 to 2 week progression that should set off alarm bells in your head.
This slide really maps out the step-by-step decline if you don't catch TBM early. You can see how it goes from those vague, I just don't feel right symptoms in step 1, and then bam, you hit step 2 with serious neurologic signs. From there, the inflammation can start messing with the cranial nerves, especially the ones that control the eyes in step 3. And if it's still not stopped, it can lead to massive pressure in the brain, coma, and even death in step 4.
So the clinical picture is starting to look pretty suspicious. How do we start to prove it? Well, your number one absolute best clue is hiding in the cerebrospinal fluid. Let's dive in and see how the CSF analysis really builds our case for TBM.
Okay, this table right here, this is pure exam gold. You have to burn this classic triad into your brain. See, unlike pyogenic meningitis, which is packed with neutrophils, TBM gives you a high white cell count. But, and here's the key, it's lymphocyte predominant. Next, the protein is sky high, which leads to that cobweb coagulum we're about to talk about. And finally, the glucose is low, because those hungry mycobacteria are just gobbling it up.
So all that protein we just mentioned, it does something pretty wild. If you just let the CSF samples sit for a while, the high fibrin content can actually form this delicate web-like clots. That is your classic cobweb coagulum. It's not just a cool party trick. The TB bacteria can get tangled up in this web, which makes it a fantastic place to get a sample for your stains.
All right, so the CSF is practically screaming TBM, but we need to be 100% sure. How do we actually prove it's Mycobacterium tuberculosis? Well, this is where you run into that classic medical dilemma. You're trading off speed for certainty.
This comparison is so important for your exams. On one side, you've got the acid-fast stain. It's quick, it's easy, but its sensitivity is honestly terrible. You're going to miss most cases. Then you've got the gold standard, culture. It's the most accurate, but it takes weeks to grow. And your patient simply does not have weeks. This is exactly why PCR and specifically GeneXpert has become the main test you'll reach for first. GeneXpert really hits that sweet spot. It's got a sensitivity of around 80%, which is a really big deal. It means you get an answer in a matter of hours, not weeks, and it's an answer that's actually reliable most of the time. And here is why GeneXpert is such a game changer. It's a 2-for-1 deal. It doesn't just tell you, yes, M. tuberculosis is here. It also checks for resistance to rifampicin, which is one of our most powerful anti-TB drugs. And knowing that on day 1 is absolutely critical for choosing the right treatment. So we have a diagnosis, or at least a really strong suspicion. What now? This is that critical moment. What you do next can literally save a life and prevent someone from having permanent brain damage.
Here is the bottom line. This is your game plan. You start anti-tubercular therapy, or ATT, immediately, the second you have a high suspicion. You absolutely do not wait for culture results. And listen to this part. Even if the GeneXpert comes back negative, if the patient's story and CSF fit the picture, you still treat. Hesitating can lead to damage that you just can't undo.
Let that sink in for a second. This is not me being dramatic, this is a fact. It's a quote you see over and over in the literature. It just hammers home the life or death importance of everything we've talked about, from spotting those vague early symptoms to reading that CSF report correctly.
And here is your why this matters stat. Because even for patients who get treatment and survive, if that treatment was delayed,
a quarter of them, 1 in 4, will be left with permanent neurological problems. We're talking weakness, vision loss, cognitive issues. It is a devastating outcome, and it's often preventable by a sharp clinician like you. So, to wrap it all up, remember that slow burn presentation. Remember that classic CSF triad: high lymphocytes, high protein, low glucose. And remember how critical early PCR testing is. Which brings me back to this final question on your screen, and I hope the answer is crystal clear by now. It's speed. Early diagnosis and the immediate start of treatment. In TBM, time is brain. Thanks so much for joining this explainer, and good luck on your exams.